So welcome everyone to the talk. Our topic today is measuring and improving patient experience, turning insights into action. And I'm very happy that Emma Walker, who's an associate director at AQUA in the UK, and I'm sure she will explain what that stands for, has accepted our invitation. She's led a variety of programs in shared decision-making and self-management supports since 2010. And she was also, if I'm not mistaken, the National Head of Service Development at NHS Direct and has long championed patient experience in the UK. So we'll start with some initial questions and afterwards we'll have time for any questions you may have. You can use the chat to ask questions, or you can raise, the familiar digital hand in Teams. But we'll start off with a question that some of you may have. What is AQUA and what is the role of AQUA? And maybe Emma, what is it you do within AQUA?
Thank you, Joop, and thank you for inviting me here today. So my name's Emma Walker. I'm Associate Director at AQUA, and I lead on their lived experience and personalised care programme. So AQUA stands for the Advancing Quality Alliance. We're part of the NHS. We're hosted by a hospital in the northwest of England. We've been around since 2010, so 15 years, and we work regionally, nationally and internationally. We're essentially an improvement organisation / consultancy, I suppose, and we focus on improvement, patient safety, leadership and OD and governance, and we have an analytical and evaluation capability. But obviously, patient experience runs through most of this work. We've worked in the area of personalised care since 2011 and patient experience since about 2013 when we set up our patient experience, our lived experience panel. And then since 2023, what we've done is we've brought our lived experience or patient experience work alongside our personalised care work.
Great, excellent. And so what would you say your strategy is on patient experience?
So I think that's really interesting. So AQUA has gone from having patient experience as one of its key pillars, I suppose, of its strategy to now underpinning and cross-cutting all elements of our strategy. And as I said, we've brought together personalised care and patient experience in that unique offer that allows organisations and or systems to pick the elements of support that they want and that are most appropriate to them. And as an improvement organisation, we always ask clients and customers to consider how they will measure success. So measurement is a key component of our strategy, because with an improvement head on, you can't improve what you can't measure. So you need to know that. And I think to really understand our strategy is to appreciate the subtle differences between the two complementary co-design approaches. So you've got personalised care that requires an organisation to develop an approach with colleagues and staff to encourage that personalised level of care. So it's that whole what matters to me type of approach, using measures such as SURE, collaborate and share. And then you've got that patient experience piece that requires an organisation to actively engage with people, to work how to shape services, sort of to redesign services that are fit for purpose, so that co-production is embedded throughout that whole organisation, and then thinking about the measures to support that accordingly, which is always a challenge.
Yeah, absolutely. And so how would you say that you measure patient experience both in terms of processes and outcomes, which is often the way these things are looked at?
Yeah, I think it's tricky. And I think if you start off thinking about measurement, when we measure anything, we need to think about the very act of measuring something changes behaviour. So even if your measurement is rubbish, the fact that I'm telling to you, I'm going to measure you, you're going to change your behaviour, you're going to behave differently. And then I think when you're thinking about measurement, whether it's processes or impact, it's about, Are you measuring something generic or specific? The timing of the measure is really important when you're thinking about patient experience. Is it straight after the surgery or the outpatient appointment, or is it over several months like a prem type of approach? I think there's that thing about scale. What scale are you operating on? How much resource do you have to collect that data? It's much easier now using things like Survey Hero and QR codes, and then response rates, in terms of, we know quite often response rates can be poor around some of those patient experience measures. So in terms of process, I don't think there's a silver bullet around measuring patient experience. I don't think there's a single easy solution. And I think it's really important that whatever you choose, it's not tokenistic. For an example, many of the boards of hospitals in the UK, we allow a patient to tell a story at a board meeting. Everyone cries, or maybe they have a bit of a playground argument with the director of nursing or the medical director, and then the patient goes out and we get on to our main business. And it's like you tick the box and miss the point. But from our regulator's perspective, hospitals are told that actually they are involving patients, which is rubbish, because they're absolutely not. So I think it can't be tokenistic. I also think it needs to be integrated into that wider operating framework of care. So Amar Shah from East London, NHS FT, he's the medical director of NHS Improvement. He says that, lived experience input is more likely to make improvement projects more successful and 3 times more likely to achieve their objectives. So I think in isolation, measurement has less success, but as part of a wider picture, I think it's really, really useful. And I think then if you're talking about process, I think there are lots of process measures around patient experience that are different. And I think you've got things like patient survey. So in the UK, we use the Friends and Family test, which is not particularly popular. It's not particularly has a high response rate. It's got 1 free text box. It's very short term. And I would argue it focuses on those environmental type of issues. Was the nurse nice to you? Did you have your appointment on time? Was the food all right? Was the ward noisy? Could you park? But the fundamental metrics of quality and maybe outcomes are less about, has it improved your well-being and your health status? I'm not sure it catches that. So I think it's good as far as it goes, but I think patient experience measures need to go a bit deeper. I think you've also got measures which look at organisational and system culture. So the one I really like is the one from the Patient Experience Agency in Australia. They've got a really nice survey that you can use as an individual, as a team, as a department, as an organisation. And it gives you a score, but it almost develops a roadmap for you. So you can use that. So it becomes more of, I suppose, an impact measure over time. So initially it's a process, but it turns into an impact. And you can look, and it's quite a good disruptor in the process. And then I think the third sort of process measure you've got is, we in AQUA have developed a measure for our lived experience partners to survey how involved they actually are in an organisation's work. So we have a panel of people. They are invited to events and meetings, but sometimes they're ignored. Sometimes they're not asked to get involved in the planning. Sometimes nobody even asks their name or why they're there. And I think, so we developed 11 statements, and we presented this at IHI back in April, about actually a measure. And again, it's a disruptor in the system. It's a way of the people managing those lived experience and patient experience representatives, so they can say that we've got these people in our organisation, we should be using them to their best effect. And it's a way of ensuring that. I think when you move on to impact and outcomes, it's much harder to find specific measures. And PREMS is one that's really good. And you've got NPS, Net Promoter Scores. But I think in isolation, they're limited. And I think it's much harder to demonstrate improvement of patient impact due to patient involvement. And I think there's something there around how you integrate it more widely, and maybe AI and technology is a way of doing that. I think in the UK, at least, the PREM stuff is anonymous, whereas the PROM stuff's not. So trying to map the two becomes quite tricky. And I think if you can map the two, then I think that's your golden nugget. I think there's also something that we've learned through our personalised care work, that actually, again, some of the metrics around demonstrating shared decision making are great, but again, they're process measures. So if you think about share, sure, collaborate, there's questions like, how involved were you? It's not the so what. So what we've done is we have try to think about how you can demonstrate a whole range of things through sort of patient experience. And we've developed a scorecard of measures. So it's a bit of a quadrant where you've got those fixed measures. So it could be friends and family test, PREM, net promoter score. But then you're also within the quadrant, you've got qualitative data. So it could be quotes, it could be films. You've got what we would call so what measures, which might be outcomes. So have you reduced complaints? Have you reduced DNAs? Have you increased, reduced length of stay or something? And then the fourth quadrant is we developed a longitudinal survey around staff attitudes over time. So when you're working in a piece of improvement work, maybe over 6 to 12 months, you question the staff so you see how their attitude is towards co-production over the period of time. And you often find at the beginning, oh yeah, we do it already. 6 months down the line, well, we're not quite as good as we thought we were. And at the end, they're going, well, we're ace at this, but the rest of the organisation are rubbish. So if you have those quadrants, and you can't always get everybody to do all of them, but it gives you a better chance at demonstrating A, process, but B, a few more outcomes as well as a result of that. It's not perfect, but it's a way that we developed to help us think about that.
Great. Thank you for that very rich response, Emma. I'm sure this raises a lot of questions with our audience. I think in among our members, not everybody's at the same level of readiness or using the same measures. So I will definitely want to open up the floor. I've also learned a new word, tokenistic, which I didn't know before.
Do you know what that means? I'm sorry, is that lost in translation?
I can guess it, but it's probably good if you explain it for the participants. So we're all on the same wavelength.
Yes, if I say sort of tick the box and miss the point, so it's like you think you've done something properly, but in reality you haven't. So, for example, we think we do patient experience because we have a patient once a month who tells us a sad story, and then that's it, and we just then ignore it for the rest of the month. And I think I don't know whether that's something that you get elsewhere, you come across in your experience, but it's very common.
I think it's something that all people that are working on patient experience face at some stage. Yes. The walk is there, the talk is there, but the walk is not necessarily.
That's a good way of describing it. Yes. Yeah. Yes.
So maybe I'll open the floor already. Just if anybody would like to ask any questions, given what Emma has shared with us, if you'd like to get something additional precision or additional information, if anybody wants to ask a question, feel free to raise your hand or drop it in the chat. Otherwise, I will continue with Emma. I don't see anybody. Okay.
Typing. I can see.
Okay.
Yeah, we have a couple of people typing in the chat, but let's maybe give them a bit of time.
Let's wait a little bit. So maybe I think Juan Pablo.
Hello. Thank you, Emma, for the time. I think it's better to ask you directly. do you measure something in the patient's home? For example, when a patient goes directly to the hospital or to the healthcare facility, we normally measure what is happening around the experience during the treatment. But do you incorporate something before or after? How do you work with other parts that are not directly in our clinical path, but in the interaction with our company or the hospital?
I think that is a really, really good question. And I think in terms of our world of patient experience, no. But I think if you think about the world of personalized care, enhanced recovery, self-management support, I think you are getting some of that. And I'm thinking around some work. There's definitely some work being done in Southampton and Bristol where they are using measures to ask patients about the baseline health before and after around shared decision making. And I think if you looked at our 10-year plan for the NHS, which is more about prevention and the move away from secondary into primary and community care, I think it's an area for further exploration. I think the hardest thing is trying to keep that patient confidentiality and to map it through. But I think, and it's about, and I suppose PREMs do quite a lot of that in terms of they often map people post. So if you've got long-term conditions, but I really like what you have to say about pre-status. And things like, I suppose I'm thinking of things like the Oxford hip or the Oxford knee score, when you ask people before they go and have their knee replacement, what their score is, what it is after, and do you know what I mean, as it goes through. That doesn't actually, that tells you about their pain, but it doesn't necessarily tell you about what's important to them, their values and their experiences. So I suspect that's a really good area for perhaps further research or consideration. So I haven't got a solution, but those are my thoughts. Yes.
Okay, great. Thank you. I see Juan, I think you have or Axel, maybe Axel?
A solution with patients in long-term care, had the option to keep a digital diary. Yes. Yeah, I think that's great. That's really, really important. And I read a piece of work recently, actually, around, it was similar, it was cancer patients who, what they'd done is they'd used the electronic health record and they'd asked patients to complete their PROMS questionnaire in between their various outpatient appointments. And what it did was, between their visits, in reviewing the findings, it increased the 5-year survival rate from 33 to 41%. So it put in, now that was outcomes. So, but I suppose it was that outpatient input. And then when they reviewed those sort of patient experiences between the visits, it meant that they, is it working? Is it not working? How do you feel? So I think that's quite interesting. And it aligns with a bit of what you were saying, Axel, which is quite interesting.
Great. Juan, I think you are typing. Do you want to voice your question or?
No.
No. Okay. Great. Maybe an additional question, Emma, if I may. How do you turn? So there's clearly a lot of measuring that's going on and a lot of things that you've looked at, but how do you ensure that it gets turned into action?
So again, it's about culture, isn't it? It's about mindset fundamentally. But what we have found is, as I said, I don't think you can do it in isolation. I don't think you can capture patient experience in isolation because it's linked to so many other stuff. So our approach has been to integrate or to try and triangulate different types of data, which sounds a bit like what Axel was talking about, because the patient needs to be part of a bigger picture, because the patient's in the center and everything is around them. And I like what we were talking about before and after care too. So what we've been doing is we're doing some work to try and amplify the voice of the patient by building on, there was some NHS Listening Well guidance that came out at the beginning of last year, which is about hearing the voices of staff and patients more. So we've been looking at how you can bring data from different sources to gain a more comprehensive insight and understanding of patient experience from multiple sources. Because I think when it's very linear or it's very binary, it's like, this is what a patient said, you don't always see the wider picture. So what we're trying to do, and I think AI has a good place in this, and if we could get a sandbox and put it all in a sandbox, that'd be really great. So taking those patient surveys, perhaps taking some of the data we've talked about, maybe friends and family tests, maybe PREMs, taking staff surveys and what staff are saying around where things are going well, where aren't, looking at complaints, looking at claims, inquests, looking at performance data, so PROMs as well as equality, diversity and inclusion data, and bringing that all together in a way that actually provides us a more rounded insight into what a patient approach might be. I think there's still a lot of work to go, and it's about balance of voice and that power imbalance about who has the loudest voice at the moment, because often who shouts the loudest is heard, and who shouts the loudest is often the clinicians, not the patients, or it's patients who are perhaps professional patients and it's not who you're hearing. And then you've got that whole equality diversity piece about actually it's always the worried well and the affluent people who are more vocal, and perhaps they are often our people who are with lived experience, but we need to give voice to our more minority populations and marginalized groups. So actually we are being more representative. So I think it's about triangulating a wider collection of data, which again, not easy, and I don't have the solution, but that's sort of where our thinking is getting to. I don't know if anybody else is sort of doing similar things.
I think Emma, Juan also raises an interesting point in the chat about how you could maybe add some other variables to kind of have, if you really want to make sure that these insights get turned into action, so that the talk becomes the walk. Okay, we definitely want to give Dennis the opportunity to ask his question. So Dennis, the floor is yours.
Thank you, and welcome back, Emma. As a service designer, I regularly meet healthcare decision makers who wonder what's good to measure, and my question is, what's the difference you can make in measuring the patient experience quality, comparing the existing services and the new services that would be released? Like, for instance, if I design a new service, what kind of different measurement tools or approaches can you provide to make sure that we really grab the very specific quality of the patient experience?
So I suppose it's a tricky one, isn't it? I think it has to be bespoke and tailored to actually what it is. And I think, again, it's looking at a number of metrics. So I suppose there's something about looking at things like access. So it's different metrics. So it might be looking at access. It might be looking at those environmental aspects. It might be looking at outcomes. It might be looking at how people feel about different services. I'm trying to think. It's difficult to know broadly without something specific. I think there's something about quantitative and qualitative too. So I think there's something about speaking to people and giving people those opportunities. And then maybe I've done some work. Yes, I've just done some work recently with the Priory, and we've been doing some talking about redesigning their advocacy service and their communication engagement service, and they're looking at redesigning the service. So what we've done is we've done a lot of co-production. So we've been out and about talking to different people, different patients on different wards in different geographies. We've actually, interesting to what you were saying earlier about, we've asked people what goes well at the moment and what would they like differently, right from pre-admission, through admission, through care and treatment, getting ready for discharge, and when they've gone home. And we've asked them to talk through those sorts of different sections all the way through, comparing it to how the service used to be. And then we've used AI to theme what people have said. So we've created themes, but also through talking to people, we've got some really powerful quotes. So, and I think you can't, when people come from the heart and say things like, when I was admitted, people talked about me as the new patient. They didn't use my name. But those stories are really powerful. So I think there's something around a structured approach. This is what we use with the Priory, from at the different stages of care, comparing before and afterwards, but also using quotes as well as data. Does that help?
Yeah, definitely. Thanks for the example.
So thank you, Emma. I have the impression that we could be on this talk for hours. It's been incredibly interesting, incredibly rich. Is it okay if we say that participants can contact you separately through LinkedIn or whatever the appropriate channel is? Because I'm sure there will be many additional questions after this very, very interesting talk. Thank you very much, Emma. So I've given information on the annual colloquium that we have, and it will be in Luxembourg from the 6th to the 8th of October. Our next talk, as I said, will be in November, not in October, with Lucien Engelen, who will be talking about the future of patient experience. And you can find this talk and all of our other talks on our website. And I believe we also have a YouTube channel. So thank you very much to you, Emma, and to all of the participants. And I hope we can see each other again soon. Have a great day.
Thank you very much. Thank you.